our chairperson for the next session, Dr. Prashant Penumadu, Medical Director, Head of Department, Surgical Oncology, SVK Tirupati, to come forward and occupy the front chair. We have a talk on perioperative management of non-small cell lung cancer. The moderator of the session is Dr. Sabita Jivnani. I invite Dr. Sabita Jivnani onto the dais. Dr. Sabita Jivnani is a professor in thoracic surgical oncology, Tata Memorial Hospital, Mumbai. I would also like to invite the panelists for the session onto the dais. Dr. Srinivas KG, Senior Consultant Medical Oncologist, Mysore. Dr. Vijay G, Consultant Hemato-Oncologist and Medical Oncologist, Chennai. Dr. Vinayak Maka, Consultant Medical Oncologist, Bangalore. Dr. Abhishek Jain, Consultant Breast and Thoracic Surgeon, Ahmedabad. Dr. Virendra Tiwari, Consultant Thoracic Surgical Oncologist, Mumbai. Dr. Imtiaz Ahmed, Chief Radiation Oncologist, Belgaum. Dr. Giridhar VH, Professor and Head of Pulmonary Medicine, Mangalore. Dr. Madan K, Oncopathologist, Mangalore. Dr. Kilimbi Yashishvi, Consultant Nuclear Medicine, Mangalore. Dr. Mandeep Sagar, Vascular and Neuro Interventional Radiologist, Mangalore. Dr. Shirley Lewis, Consultant Radiation Oncologist, Manipal.
Good afternoon. I think this is the pre-lunch session and we've also been asked to cut down the panel to 20 minutes. So let's get started soon. In the interest of time, I would request all the panelists to please keep their answers short and crisp so that we can try and complete as much as possible in these 20 minutes. So starting with the panel, these are the panelists, as you all know, and we'll start with the first case. Our patient was a 47-year-old lady who presented to us with cough, chest pain and dyspnea since 3 months. No addictions, diabetes mellitus, history of pulmonary tuberculosis. So I'll ask our pulmonologist, if this patient came to us, how would you investigate? She's 47, no addictions, diabetes and TB in the past.
Yeah, first would be to clinical history and then the radiological evaluations. Based on that, we have to take it forward.
What radiology would you do? X-ray, CT, what would you like to do?
Chest X-ray would be the first thing to do.
First thing, chest X-ray.
Yes.
Okay.
That would, it's not for a diagnosis, but to ask for the which is the next level of investigation. So based on that, see, it can be pleural effusion, or it can be a mass lesion, or also subsequently we can decide whether we need a bronchoscopy or CT, all those things based on the chest X-ray would guide us to the next radiological investigation.
So she came to us with a CT which showed this. It was a mass lesion in the right upper lobe which was abutting the chest wall and the fissure, going on till the hilum, till the central bronchus, and a little bit of transfissural extension also. I'll play the lung window also. Yeah. So this is what the scan showed. So now coming to the oncologist, now if this patient has come to you, what would be your next investigation? Virendra, you want to start? I'll keep playing the scans.
Yeah, so right upper lobe lesion with the transvisceral extension going into lower lobe and also very close to hilum as well as chest wall. Looks suspicious. First thing is to get a histological confirmation. So a CT guided biopsy is what I'll prefer.
Abhishek, see, biopsy first or anything else first?
Ma'am, I think CT guided biopsy.
Biopsy first.
Yeah.
Anyone thinks this could be infective by any chance? She has history of pulmonary tuberculosis. She's a diabetic. And we know that in diabetics, we get a lot of consolidations. So anyone thinks this could be infective? Wants to avoid biopsy, wants to give a trial of antibiotics?
The symptom duration is from 3 months, you said.
No, I didn't say the duration actually.
Chest pain and dyspnea from 3 months.
Yeah, 3 months, yes, 3 months.
I don't think it in an infective way.
So all of you will agree that it looks suspicious for malignancy and we would go ahead with biopsy. So, sorry. There's something wrong, 1 second. Yeah. So we got a PET CT and a bronchoscopy done. Because it was a central lesion, we were hopeful of getting a biopsy by bronchoscopy and also collecting the bowel for culture because she had fever also, and also for cytology. So this is the PET CT confirmed the findings of the CT scan. We have a nuclear medicine specialist with us, and such a large lesion, some patchy heterogeneous uptake. I'm sorry, I don't have the video of the PET scan. A right hilar lymph node, which was 1 centimeter, but no significant mediastinal lymph nodes. So, in this lesion, what do you think the stage would be? I've already given the answer.
Yeah, so I think it's clear cut stage T4 and 1-3A, and
Would we do by MRI brain for all these patients?
yes. Yeah.
If it
More than
is-
any tumor more than I think 4 centimeter, we would always like to do a MRI brain.
If a lesion is less than 3 centimeters, in some cases, can you avoid MRI brain? Anyone else, Dr. Srinivas?
If it is a NSCLC, definitely.
Definitely do MRI brain.
Less than 4 centimeter, we can avoid.
We can avoid,
If
okay?
you're planning a curative treatment, I would like to get a MRI.
MRI brain done.
So, especially in adenocarcinoma, even if lesion is 2 to 3 centimeter, there are chances of brain metastasis, and the management will completely change. So T1A is the only subset where you can avoid, whereas T1B, T1C adenocarcinoma, it is better to do MRI and then proceed.
So actually the ACCP guidelines in 2021 have said that a squamous carcinoma and less than 3 centimeters, the yield of MRI brain is very low. So in their Choosing Wisely campaign, they have said we can avoid MRI brain in these cases. So this patient obviously now goes for a MDT discussion, and all of you are there in the MDT. So what are you thinking? Is this patient curative, non-curative? We've all seen the scan. We have a PET, patient is non-metastatic, and the biopsy is squamous carcinoma. So starting with a medical oncologist, what are you thinking?
As you rightly said, if a surgeon can still operate this lesion, that would be good. If surgery is not possible, then other discussion will open up.
Okay, both the surgeons, what do you all think, one by one? Are you all happy to take up this patient for surgery? 7 centimeter lesion and hilar lymph node, or do you want to do anything else?
No, T4N1, before considering for surgery, I would like to get a functional workup also done.
Okay.
So, maybe not now, but if functional workup is good, maybe in future she can be, planned for a surgery. But if she is clinically fit with functional workup also, then we can consider of some sort of down staging and then plan for
Okay,
surgery.
if this-
Workup and medicinal staging, these are two important things that we lack right now before going
Right.
or taking a decision.
Abhishek, what
Yes,
about you?
My answer would be the same too. I would be planning most probably for some sort of neoadjuvant treatment in this patient. ma'am.
In this patient.
Yeah.
If this patient came to the radiation oncologist, what do you think? Do you want mediastinal staging? Do you want functional workup? Or you're happy to start the treatment?
I guess we would get a functional workup done because the
Okay.
lesion is quite a large one. But we would, since it's a single station, we
Yes.
would definitely want an opinion from the surgeon whether they're going to think that this is an operable one or not.
Right.
So if operability is decided that it's not going to be operable, then it's a candidate for definitely.
Okay. So, what about mediastinal staging? Before treating with radiation, definitive concurrent chemoradiation, do you want mediastinal staging?
Normally, there is no concept of elective irradiation to the nodes. So whatever
Right.
is seen is being irradiated here.
Right.
So in case the already evaluation has been done, it's an N1 disease. So the primary as well as the involved node will be addressed when we are doing radiation.
So I'll just come to our radiologist and to our nuclear medicine specialist. What do you think is the sensitivity and specificity of PET? And do you think invasive mediastinal staging is required? In such a case, 7 centimeter lesion, PET is done, only hilar node has uptake. Would you still advise the surgeon or the radiation oncologist to do invasive mediastinal staging?
If there is no other node, if there is no other node on the CT, so only the right hilar node is there, right?
Yes, only right hilar node.
Then I don't.
No need for mediastinal staging?
This patient, I would definitely like to plan a invasive mediastinal staging since there's a T4, N1. If N1 nodes are there, then it becomes a clear-cut indication for a pathological N2 staging.
Yeah, right.
So I think EBUS or I think EBUS, we would go ahead with EBUS.
So PET-CT has a false positive and a false negative rate of 20% each in our population.
He also has a history of TB.
Yes,
so
she
I definitely want to do a mediastinal staging.
Right. So we have not seen any enlarged mediastinal nodes, but in a lesion which is coming till the hilum, which is central, there can be something which is called as a shine-through effect. And even if the nodes are there and they have uptake, they may not be seen because of the excessive SUV uptake by the primary. So in any case, anything which is more than 3 centimeters and is not peripheral, that is in the outer third of the lung, merits invasive mediastinal staging. And like Abhishek said, and earlier Virendra has already educated us regarding the optimal mediastinal staging, ESTS guidelines also said the same thing, that EBUS is the first modality, and if that is negative, then you confirm with mediastinoscopy in most of the cases. So quickly, anyone knows the definition of optimal EBUS and adequate EBUS? Pulmonologists, surgeons, intervention radiologists, you guys are the ones doing the EBUS. What is an optimal EBUS and what is an adequate EBUS? Virendra, go ahead.
So, ideally we should screen all stations starting with the contralateral hilar, rule out N3, then rule out N2 in all cases. But if you have to see what is optimal, then at least 2 ipsilateral N2 station and subcarinal. But
Yes.
whatever you see suspicious needs to be sampled, 3 passes from each suspicious node.
Yeah, so that is an adequate EBUS, 3 stations, 3 passes from each node. Optimal is you stage the entire mediastinum, possibly hilar also, and also do EUSB. So that's an optimal EBUS. And to coming to this question, is mediastinoscopy always required in the case of a negative EBUS? So most of us are familiar with the MEDIAS trial. How do we apply this to the clinical setting? In this case, if the EBUS comes negative, will you do a mediastinoscopy?
Yes, definitely. Since it's a central huge tumor,
Yes.
more than 7 centimeters, so I think it becomes a case for a follow-up mediastinoscopy.
Right. I would like to involve our pathologist here. So the biopsy is squamous carcinoma, and one of the surgeons has already mentioned I would like to downstage the tumor. So do you think NGS is warranted on this biopsy, even though it's squamous?
Yes, ma'am. I think NSCLC, even though it's squamous, the alterations we don't see as frequently as in adeno. Maybe EGFR ranges around 1 to 5%. So even if it is squamous, NGS targeted panel is still indicated in this case.
So even in the non-metastatic setting, you would advise NGS or only specific markers is enough?
Targeted NGS panel is still indicated.
Targeted NGS. Okay, please go ahead.
So in the perioperative or neoadjuvant trials, 3 subsets were excluded. This is squamous, I understand. ALK, EGFR and ROS were excluded in the study. So for that sake of thing, we have to do, otherwise there is no indication.
Right, right.
So, Dr.
So this is
Sabita,
the ESTS. Yeah, yes, Prashant?
Yeah, if I may ask the panel, so would your invasive mediastinoscopy, not the EBUS, would you take a decision based on your definitive treatment that you're planning? Let's say if you're planning for CT-RT and not surgery, would you still want to do mediastinoscopy after negative EBUS?
No, I think they said only EBUS. That's what.
If the patient goes for CT-RT from a radiation oncologist point of view, invariably she'll go for a PET scan because a PET-based planning is more essential when we're doing a radiation plan. So if it is a negative PET, and then probably that could happen.
Okay, but madam asked for a EBUS. She said.
I think that can only be answered if we get a clear-cut idea of the pulmonary function test of the patient first. So that would decide whether we would contemplate surgery in that patient or not.
Right.
So that's why I brought up this point, because first I think we need to finalize on what the plan, and then because we want to do a mediastinoscopy.
So because she's a 46, I think age is 46. Right?
47 years.
So the bad PFT would be the only thing which would prevent us from doing and going ahead with a surgery, either upfront or after NSC.
Okay.
So all the perioperative chemo immunotherapy trial, they were all for a potentially resectable patients.
Correct.
So you will chase very aggressively for them to label whether it is resectable or not, because that becomes very vital.
Yes.
Because unless you are potentially resectable, you are not going to give a perioperative therapy.
Completely agree, sir.
That becomes very important.
Right. So these are the pulmonary function tests, 65%, 15% reversibility, DLCO was good, 6-minute walk test was almost normal, good 2D echo, but her sugars were uncontrolled. So what further evaluation would you need if you are thinking that this is resectable but there's a possibility of pneumonectomy? Would you think of doing anything more? Because this is peri-operative management, so we are not talking only of multimodality, we have to delve deeper into functional evaluation.
So there is a slight possibility of pneumonectomy looking at the scan because tumor is reaching all the way till interlobar pulmonary artery. So in that case, I would also ask for a ventilation perfusion scan, which will give me a better idea about predicted post-operative values rather than the PFT and DLC alone.
Right, because the
Can I ask you something?
Yes, please.
Will you do a mediastinoscopy or not?
We would do a EBUS first.
What is the purpose of doing that? No.
I didn't get it.
The purpose of doing it? No.
Of doing a mediastinoscopy if the EBUS is negative?
Yeah.
If the EBUS is negative in a small lesion like they showed in Medias trial, T1, T2 lesions, you can forego. This is T4. Chances of N2 higher and missing N2 on EBUS. In our own series, it is 9.6%, which is published in the ERS paper in 2017 from our pulmonary physicians. So in a patient who's a potentially pneumonectomy candidate, you would want to know the nodal status absolutely accurately.
What happens if it's positive? What happens if it's negative?
If it's positive, you would tend to go towards CTRT. If the patient is N2 requiring a right pneumonectomy, the patient would do equally well with a right pneumonectomy versus surgery. If the nodes are negative, you would go more aggressively towards the path of surgery.
Okay, then what is the purpose of downstaging now?
Downstaging, downstaging has a survival advantage as shown in all the chemo and immuno trials, but even before you downstage, in most of the trials they have done mediastinal staging and then downstage.
Now, can I take that question?
Yes, please.
So the purpose of medianoscopy is you have to aggressively chase if the patient is N2. Correct. Your question of resectability comes down and you cannot give a perioperative.
Okay, I'll ask you one thing. Abhilay, you feel this is not resectable?
It is resectable, sir, but there is a chance of pneumonectomy. It's going to the interlobar pulmonary artery.
No, so Dr. Ayyappan, N2 disease with pneumonectomy has a very poor outcome.
Yes.
So that we need to be...
I started the discussion for myself. Is the mediastinoscopy important? That's what I want.
Yes, it is, sir.
T4, N2, straight away we are going to plan a CT
for
this patient. Otherwise, it would be a NACT.
If it was not T4, we would not chase it so aggressively.
That is why we want
pathological. So if you're thinking of pneumonectomy, there are other tests that you would like to do to make sure your patient is absolutely fit if your pulmonary function is borderline. So what happened further was that we did a limited panel. We did EGFR and ALK, and these both were negative. We got the patient into pulmonary nutritional rehabilitation, did a full prehabilitation workup, and did a EBUS, which showed a subcarinal node was positive. So the patient was now T4A, N2A, M0, 3B. But still she's young, she has good general condition. So we got her back to the MDT, and the discussion was, this is still a potential pneumonectomy and this is N2. So most of the panel in the JC tended to go towards concurrent or sequential CTRT. So I would like to ask the radiation oncologist, when do you consider sequential chemoradiation? Do you consider sequential in T4 or this you think is okay for concurrent?
So looking at these images, I think this is reasonable for concurrent CTRT. So only if there is a multi-station going up to N2, N3, where we think that the lung doses are not going to be met, in those cases, if the patient is still fit enough to receive chemo, should receive chemo and then consider for sequential RT. Otherwise, if the portals are going to be reasonably okay and you're able to meet your constraints, I would go with concurrent.
You'll go for concurrent. So the patient, because she was very young, she was very keen on surgery. So we decided to give neoadjuvant therapy first. Patient was not affording for immunotherapy, so got only neoadjuvant chemotherapy, 4 cycles of paclitaxel and cisplatin. And this is what the scan showed after 4 cycles of chemotherapy. On the mediastinal window, we couldn't see the lesion, and on the lung window, it had become a cystic cavitatory lesion, which was just this, and there was nothing else. So we did a PET also, no uptake anywhere. So now what do? Radiation oncologist, you were planning this patient for radiation. That was decided in the joint clinic. So is radiation or concurrent CTRT still possible in this cavitatory lesion?
If the plan was to do a CTRT, and if this is a kind of picture what we are getting, because I mean it's a complete response case, so it's a challenge for a radiation oncologist as well. So what we normally do is we have the baseline scans. The baseline scans can be blended with the present scans, and we can somehow delineate the area where we feel can be justified to do radiation. And of course, the lymph node stations in the mediastinum, we have a clear-cut guidelines which volumes to be taken in which lymph nodes are involved. So we can do a...
You can still do CTRT in a cavitatory lesion?
Yeah, it's not a quite large cavity.
Okay. So our radiation oncologist said, if you think the patient is fit, please take her for surgery because the response is excellent and they were not very sure that they will be able to deliver good doses to this cavitatory lesion. So we evaluated her again and she seemed to be quite fit. The sugar was still a little bit uncontrolled, but she was okay. So coming to Virendra and Abhishek now, would you try VATS in this case, or are you happy with the open approach?
I'll prefer open because of the nature of response. It's a cavitatory, little bit of, handling may cause rupture. So
yes.
Open I am more comfortable than minimally invasive.
That would be a major concern, yes. Abhishek, what about you?
Yeah, I think if expertise is available, why not minimally invasive?
Okay. You're not worried about rupturing the cavity?
No, we'll have to be definitely careful while going in, but I think we can proceed with minimally invasive and then later on.
Okay. So she underwent a right upper lobe sleeve with segment 6 excision because there was a transvisceral extension. We reconstructed right main to intermedius anastomosis. She had some air leak in the post-op which was not very worrying, but on post-operative A, she started spiking. And this was the bronchoscopy which showed there was a minimal dehiscence of the anastomosis 2 millimeters at 12 o'clock position. So quickly the last slide now. Sorry, the slides are not moving that well. And this was the post-op scan which essentially showed the same thing. There was a loculated collection and there was some consolidation. So what would be the next line of management? Conservative, explore, do a completion pneumonectomy or try stenting. Anyone has any opinions? Abhishek, what would you do? Would you explore this patient with a 2 millimeter fistula or would you conserve?
Yeah, I think re-exploration.
Re-exploration. Would you go in with a plan of a pneumonectomy?
Yeah, definitely.
You would?
We'll have to counsel the patient.
Virendra?
So stenting and completion pneumonectomy I will not go for because both have its own complication. If you see bronchoscopy, there was a slough along the suture line.
Yes.
So even my pneumonectomy stump, it is at higher risk of opening up and she is a diabetic patient,
yes.
right? Pneumonectomy, it's no in this situation. So I'll prefer with conservative CT-guided pictal and all, but she will need exploration and
yes.
I'll cover that dehiscence with some vascularized muscle flap.
Yeah, so that's exactly what we did. We covered it with a serratus flap and this was the histopathology, a 6 centimeter cavitatory lesion with some foci of squamous carcinoma, all margins negative. 2 out of 14 lymph nodes, 1 hilar and 1 subcaninal, showed microscopic foci of squamous carcinoma. So this is a persistent pathological N2. So what does the panel feel? Does this patient merit adjuvant? Because we discussed her in the MDT, she's had a stormy post-op, ECOG has worsened and hospital stay is more than a month. So adjuvant, yes, no? If adjuvant, what adjuvant? Any of the radiation oncologists want to give post-op RT?
No. Based on the lung RT
Okay,
trial.
coming to the medical oncologists, adjuvant chemo, adjuvant immuno?
So N2 disease.
N2, persistent N2, but ECOG has worsened. Hospital stays more than 1 month. She's had an exploration. She's uncontrolled diabetic.
She has completed 4 cycles of chemo before.
Yes, she has completed 4 cycles.
Only benefit is adding up, the benefit of immunotherapy is there in residual disease and the PDL negative. Definitely would have offered adjuvant immunotherapy if possible.
Atizo?
Anything is fine.
Possible. Right. Okay. So this is some of the slides how we decide between neoadjuvant and adjuvant, but the time is up. So I would just like to thank all of you and leave you with this slide. And maybe next time we'll get adequate time to discuss in depth. Thank you. Thank you for being such an interactive and great panel. Thank you, everyone.
Thank you, ma'am. Thank you to all the panelists. moving on to our next session, I invite the moderator for the next session, Dr. Rajiv Rajendranath, Senior Consultant Medical Oncologist, Apollo Cancer Center, Chennai. We'll be talking about oligometastatic non-small cell lung cancer management. I also would like to invite the panelists onto the dais. Dr. Naveen Anvekar, Consultant Medical Oncologist, Mysore. Dr. Arun Chandrasekhar, Consultant Medical Oncologist, Calicut. Dr. Lepakshi K, Consultant Medical Oncologist, Mysore. Dr. Srijan Shukla, Consultant Surgical Oncologist, Hyderabad. Dr. Kush Shah, Consultant Surgical Oncologist, Ahmedabad. Dr. Durga Purna, Consultant Radiation Oncologist, Cochin. Dr. Atyaman, Consultant Radiation Oncologist, Mangalore. Dr. Dharma Shetty, Consultant Pulmonologist, Mangalore.
Good afternoon. I would urge our panelists to quickly settle down because it is oligometastatic and we have been given 20 minutes. So we will start quickly. So as my panelists settle in, I will start off with a clinical case which we are dealing with. So he was a 62-year-old male smoker, 20 pack years. He had significant right shoulder pain. He presented to the emergency with a lot of pain. He is a busy professional. Now he is significantly restricted due to severe shoulder pain, most probably a referred pain. So quickly we'll go to the guided biopsy which of the lung lesion, and that turned out to be a carcinoma, probably a spindle cell variant of non-small cell carcinoma. And there was a right axillary node which was quite significant. I'll show you the PET CT, which was FNAC done in the same procedure, which was also positive. So after a series of IHC, finally they told it's a poorly differentiated carcinoma, probably a spindle cell variant non-small cell carcinoma. So this is the initial PET. So the PET shows why he had a lot of pain. It was a referred pain to the right shoulder because of the pleural infiltration and rib erosion. And you can see the right axillary lymph nodes. So the PET CT also demonstrated there was a left adrenal lymph node. So we have a right axilla, which is technically a metastatic node, and a left adrenal gland, which is metastatic. But otherwise, there's no wet disease, there's no pleural or pericardial effusion. So I'll ask one of our medical oncologists, Dr. Arun, now how would you proceed if it comes to your OP?
Yeah. So as per the oligometastatic definition, yeah, it does fit in a single adrenal and axillary node. We have a spindle cell variant of non-small cell carcinoma, so probably I think only the PET was done. MRI brain would be one thing to complete the staging, especially oligometastatic, so as not to miss something out there. Then we're going to have obviously a disciplinary board discussion. The surgical oncologist, radiation, everything. So just set the intent of treatment. Is this true oligometastatic, and are we going to go radically? So I think the surgeon has a big say in this, where post-treatment, would it be resectable down the line? And once we make that decision, then probably systemic therapy first, followed by a radical treatment, if everyone agrees, would be my flow.
Okay, so let's say if he's admitted and is in severe pain, what would be your initial line of systemic therapy? What is the minimal information that you would require before you start?
So systemic wise, obviously biopsy has been sent for the NGS. We don't wait for patients who are symptomatic. So I would start with chemotherapy, depending on the patient's fitness. If it's PS2 onwards, single agent carboplatin also, or something weekly paclitaxel is something that we do use. So since we have this thing, probably paclitaxel carboplatin, since it cover non-small cell, both of them.
Sure. Dr. Lepakshi, do you believe in this concept of oligometastatic disease in lung cancer? If that is the case, which is the case which, as Dr. Arun was telling, which you will really bring it up to the MDT? For example, here we have two sites. We have axilla and adrenal. Brain will take it as free. So is this a right case for us to discuss upfront as a oligometastatic disease, or what do you think where you should be really discussing? Yeah.
Yes, sir. Oligometastatic, definitely in this case, right axillary and adrenal, I will discuss with my surgical team whether it is going to be operated later, so that I can kept in a mind saying that it is a curative intent, plan is like curative intent. And especially in the, it's a special spindle cell carcinoma, probably even chemotherapy response is not that much great. And only the best modality is immunotherapy and surgery. Even radiotherapy also little difficult in this case. So I would like to start with chemotherapy, and meanwhile I will discuss with my surgical and radiation oncologists whether in later, if they responded very well, whether we can go ahead with some radical treatment. So that along with that I would like to do some immunotherapy markers like PD-L1 and other molecular tests also I would like to do.
From a surgical oncology perspective, do you think is there any subset of oligometastatic disease where you will operate both the primary and metastasis upfront? If so, what do you think are those subsets which we should be discussing?
So I think once we have labeled something a metastatic stage 4 non-small cell lung cancer, upfront surgery won't be an ideal option for any patient. I think systemic therapy and systemic control is the first goal. But I agree to the point that you need an MTD discussion. And the reason for that is if we are ever going to contemplate surgery, we need to make that intent clear on day one. So if I see this patient on day one and I know this is going for some form of systemic therapy, but if we need to have the conversation with the patient and amongst each other about surgery, A, we need to know the patient's pulmonary and cardiac fitness. B, I also want to look at the mediastinal lymph nodes because that will have bearing on whether we'll consider this patient for surgery or not. So on the PET we saw the same type of lymph nodes which was seen in the axillary, in the paratracheal and subcarinal stations also. So I would prefer to have that histology confirmation through an EBIS on day one rather than start away the systemic therapy and then later we don't know whether we had a positive mediastinum to begin with or not.
So what I would understand is even if you have an axillary proven disease, you would still like to stage the mediastinum because you feel at some point he'll be a surgical candidate. Is that what?
So this case is a tricky one because there is a chest wall involvement. We can see the axillary node immediately next to the primary tumor. So the pathway through which it has reached the axillary node might be different here. So if it's a axillary node only positive, the mediastinum nodes are reactive, then I would consider surgery as a good option for this patient from day one.
So if I have a small lung tumor and a small brain, again, you're not going to consider surgery. That's what I could hear from you.
No. On the other hand, in fact, if it's a small lung tumor which is amenable to a lobectomy,
yes.
Patient is fit and patient has only 1 or 2 extrathoracic sites of metastasis, then we should consider surgery not on day one, but after systemic therapy.
So that's the question I was trying to ask. So there is no role of surgery on day one. Yeah.
Actually, I would partly agree and partly disagree too, but most of the patients with solitary brain tumors would actually need surgery for the brain first because they are space-occupying lesions.
Sure.
And majority of them actually, these oligometastatic, we actually find out pick up these lung lesions after a surgery for the brain tumor.
So the sequence would be brain first, then systemic, and then go up for the primary brain.
Majority of them would have undergone, optimal debulking and then come to us rather than we picking up them both at the same time.
Sure.
And also interesting in this case is axillary lymph nodes to be considered regional or metastatic is a question because it's infiltrating chest wall here.
So I hear things are easy because adrenal uptake is also there. So
adrenal.
Yeah. So so we started him on nab-paclitaxel and carboplatin as Arun was suggesting. And we didn't have much information on the IHCs because as I told he was in severe pain and we wanted to do something about it. So if you look at the sequencing of treatment, I think a little bit that has come out of it. I think it's systemic therapy followed by local consolidation bar metastatic directed therapy. That's going to be the standard in majority of the patients. Is there anyone in the panel who doesn't believe the concept of oligometastatic and say that these are all, group of people getting some data out with not much of prospective evidence and let's do only with systemic therapy? Any medical oncologist can tell us. Arun, what do you think? Probably. No, we'll stick to non-small cell. You believe in the concept of oligometastasis. Okay. But then we will come to know that there is no one-fit-all algorithm, and it keeps changing based on how, at what time point we are detecting this oligometastatic disease. So I think the most important slide from this case presentation is this one. So the PDL1, the TPS scoring was 100%. So then the problem started for us. We didn't have our NGS results in place. So from the medical oncologist point of view, how would you deal with the next cycle? He has a huge tumor burden. We need to reduce his pain. We need some response. So what would be your second cycle?
So I would like to continue with the previous cycle. Without NGS, I wouldn't start.
So I think most of the places it comes within 2 to 3 weeks. So let's say if the NGS report is not available with you, what will be your plan for the second cycle?
I will continue with the same cycle which was given previously, because the carcinoma component, we are not sure whether it is squamous or whether it is adeno component. And using taxane with platinum is the safest thing, I feel.
So with PDL1 100% also will sit tight.
Yeah, because in case of EGFR positive or ALK positive, you are starting immunotherapy will be determined.
Sure. I think we were a bit desperate, and so we started on nab-paclitaxel, carbo, and pembrolizumab. So I think the thoughts has been told, and then we got, luckily for us, the NGS turned out to be all negative. There was no mutation addiction there, which is sort of understandable in a sarcomatoid variant of non-small cell lung cancer. Now the next question is, now we have had a tumor of PDL1 100%, and what would be your subsequent cycles? Would you like monotherapy with pembrolizumab, or would you still consider continuing chemo plus immunotherapy? Dr. Lepakshi.
So probably this patient responded to chemotherapy also, I think.
Yeah, he had actually, yes, you're right. So after first cycle, there was significant improvement in pain. He started.
I will continue chemo plus immunotherapy.
All agree? Okay. So I think that's a reasonable practical point. So we will continue. And the complex process which happens in the oligometastasis is still not very clear. But the final clinically detectable metastatic tumor, so it's somewhere between your MRD and your obvious systemic disease. Whether that's going to make a difference by treating it different, we will see what is the evidence. And we'll also know that the treatable usually with a localized intervention. And the difference which I think our panelists are also trying to bring about is that oligometastasis are even at, when it is present at presentation or at subsequent time period, it is more indolent. You have some favorable conditions with less metastatic potential, and you may have some T cell clones which may work in favor of you. So again, I think we partly discussed this. So if we'll bring in the pulmonologist also. So if tissue is an issue, you want all these tests to be done. So you make sure enough tissue is there and then start treatment. What's your workflow like?
No, we work with the tissue that we have these days. Means our pulmonologists are attuned. They know that a lung cancer patient, they get at least minimum 4 cores. Some of them 5. Beyond that, the risk of pneumothorax is quite high. Yeah. But at least 3 to 4 cores we do get. And I don't think we have an issue with that. After that, less cellularity. We do a liquid biopsy. It works pretty well. We've had decent responses. Only thing, personal experience-wise, the more expensive panels, the better the results that we've seen. So sure. I've had patients where our Indian things were negative, but this patient was a young female non-smoker. So, it kind of irritated me that I didn't get anything positive, and we sent a garden panel and it picked up a rare EGFR mutation. So
that brings us to me the next question, that will you be sending liquid biopsy in parallel, or you will wait for the tissue to be inadequate and then we will?
So again, that depends on the patient. Yes. So I give this option to those people who can understand it. Like we've had doctors, parents who wanted to get the complete panel, and especially when I have a patient who I suspect that it's going to be positive, not a heavy smoker, something like that, a young female, and they are affordable, I do kind of send it in clinical practice, but as per the guideline, just the tissue is more than enough.
Sure. So I think after 2 or 3 cycles, when we did the repeat PET scan, as expected, there was a significant reduction. I don't have the films, but nearly complete metabolic response and near complete remission. So that's where we really brought in the MDT. So I would like, opinion from each of you. Surgical oncology, what would you think? Is it a right case to operate?
I think that decision will be taken upfront when we discuss the MDT. As per the staging, the patient is a case of multi-station N2 and I think opposite hilar, so N3. So definitely if he is responding, he will require some local consolidated treatment. But I think in the form of radiotherapy for the local part. For adrenal, we can discuss lab adrenalectomy or SBRT with radiation oncologist, and same with axilla.
So, ma'am, what would be your, treatment fields? Like, we have had a good response in the axilla, and then we have had a very good response in the primary. Mediastinum, there are nodes, and there is adrenal. So, first you tell us what would be,
I would think about the axillary node also as a draining node, as a regional node, treated to 60 gray 30 fractions, which is standard.
So
treat the primary, the X-primary, the axillary node and the mediastinal nodes to 60 gray in 30 fractions. And then probably follow up with SBRT for that solitary metastatic.
Yeah, that's so.
Adrenal, that was there. But
so I think there was
again a problem because it is
Yeah, so there was a lot of discussion in MDT about whether we should address surgically the adrenal or radiation. So what has been your experience on addressing with radiation? How much will
because
be the control?
It has responded so well to, there has been a complete response. I would probably just give 30 grade 10 fractions at this point to the adrenals. So maybe if a surgery can be done, that would be better.
Sure. So I think exactly the same things were discussed, and finally he went on to receive the complete radiation to the primary and axilla, and we also discussed about adrenalectomy, or the other option was EBRT to all sites. Patient still wanted time, so we went ahead with pembrolizumab, a few more cycles as a single agent, and then he developed myasthenia gravis like symptom. Luckily for us, it was grade 2. He responded well to steroid. The neurologist did all the testing, and we had the antibodies which were positive. And that was one of the first patient which I saw, at least. So we had literature search, and they told that you should not be re-challenging pembrolizumab once you developed myasthenia. So then things were pretty clear because the PET-CT was in complete remissions, and we did the radiation to primary and axilla. We offered adrenalectomy, but patient was not keen. And since the MRI showed a complete response in the axilla, in the adrenal, he was not very keen for RT to the adrenal also. So basically, he underwent RT to consolidation RT to the primary and axilla. We have been all in unison with all this approach. But what is the evidence? Do we really have evidence to say that we consolidate all this and then we are going to get improved survival from the radiation oncologist? You feel that metastatic directed therapy is here to stay, and are we going to have more and more prospective evidence on that?
Robust level 3 evidence is going to be difficult to get, but then we are going to get enough in retrospective data and probably other historical comparisons.
Yeah, I think that's where we are. We do. Yes, you wanted to tell something? Yeah.
No, I think based on the available data that we have, it's pretty encouraging. We don't have OS data yet, but the PFS data is pretty strong, where we are comparing median time to progression between 13 months versus somewhere in 40s. 43, 44 months. So I think the available evidence for local treatment is pretty good. Obviously, we don't know which form of local therapy, and I don't think that data will ever come up.
Sure. I think the complaint from medical oncologists will be that PFS is never good for a drug, and there will be a lot of discussion on OS disadvantage, but a little bit of PFS we'll take with a local consolidation, but I fully agree that's what we will do with the current eligibility. From the medical oncologist, will you re-challenge? Will you be confident enough to, because it was grade 2, steroid responsive.
No, sir. Myasthenia gravis, with myasthenia gravis and also with GB syndrome, also with immunotherapy induced.
Yeah.
Most of the times it is permanent and the mortality is very high.
Sure.
So I would not risk with a re-challenge.
So I think again we went back and forth, and we had some international experts also being called for, but they said it's a class effect. We thought we'll change to Atezo, whether it will be lesser, because there was less reports of myasthenia with Atezo, but they said don't re-challenge, you will be in trouble. So that's what the literature review also says. So the patient was initiated on pemetrexed maintenance for whatever is worth. So as of now, he's doing well. His MRI brain in between we did because of a seizure episode, which we thought was a CNS metastasis, was normal. And as of now, he has completed 54 months of pemetrexed maintenance. He does all his work. So I don't, do you agree? Should we stop? Will you be brave enough to stop? Or we can tell that it's all due to Pembro, and shall we just stop Pem?
So that's always the question. With oligometastatic, what are we achieving? Can we give stoppage? In my experience, especially in breast, especially with HER2, stopping the medicine is detrimental. There's studies where detrimental challenge may not work.
So go as much as possible.
Upfront metastasis and even complete response stopping is detrimental. Only thing I would probably make it once a month, probably 4 weeks, and even I've done a 6-week protocol of pemetrexed, but other than that, continued till it as well.
Sure. From the pulmonologist point of view, so we have been, he continues to smoke. He has all these COPD changes. So what are his, tips and tricks we can give us on how to do the cessation?
We just refer to the psychiatry department. So varenicline is apparently pretty good is what they say, but the availability is problematic. So probably he is keeping himself fit for the next dose of immunotherapy because, it's going to work well if he's...
I think it worked in our advantage. So I think definition itself, there is a lot of not confusion, but different parties believe in different definition. But at least less than 5, 1 or 2 systems is what we should be looking at when we look at oligometastatic directed therapy. Very interestingly, there are a lot of signature studies going on whether the oligometastatic has a different signature which will help us treat them better. Because even in oligometastatic, if you have particular unfavorable genomic signatures, they may not do well. And of course, as I told, it's a continuing spectrum of MRD, oligometastasis, and systemic metastasis. So if you can, come back to MRD and treat them, maybe we can reduce the, possibility of this oligometastatic disease. With this, I would stop here, and I thank the panel for a very interactive discussion, and I think since time is up, we'll stop. Yeah.
So this is about FLAURA2, what I'm going to speak on. So EGFR mutation, lung cancer, mutation positive lung cancer, if I have to give an overview, is in Asia and in Indian continent, it is more prevalent, around 40% in Asians compared to 20% in non-Asians. The incidence of EGFR mutation among Indian patients is around 33 to 39%. In our institute, KMC Manipal, when we analyzed the data, out of around 98 patients where we analyzed around 46 patients, approximately 45% of the patients were EGFR mutation positive. The most common EGFR mutations are deletion in exon 19 and exon 21 L848R point mutation, which we all know. So coming to the outcome of TKIs, yes, is the TKI doing good in EGFR mutated patients? Yes, of course, we have 3 generations of TKIs, so of course TKI should be doing good. Started from geftinib to osimertinib. If you see the PFS, it has increased dramatically from 9.5 months of geftinib with IPAS trial to osimertinib, which is around 18.9 months in the FLAURA. So OS also substantially has increased from geftinib to osimertinib, from first generation to third generation TKIs. So it was around 22 months with the geftinib in IPAS trial. In FLAURA, the OS is just above 3 years. It's around 38.6 months. So are we happy with this? So I think everybody would tell that we dil mange more. So we want to get more out of these good subset patients who are EGFR mutation positive. So in those patients who are EGFR mutation positive, and when the data was analyzed, when the patients were put on either first or second line, and when the patients came for osimertinib, there were a lot of patients who had a loss of EGFR T790M mutation. So one of the strategies, it can be because of intrinsic EGFR independent or EGFR dependent mutations, which will result in the failure from EGFR anti-EGFR therapy. So the combination of EGFR TKI with other anti-cancer agents, example chemotherapy, radiotherapy or targeted therapy, has recently emerged as a strategy to avoid or at least delay the emergence of acquired resistance to EGFR TKI with the intent to improve the clinical outcome. So even in FLORA trial, at 36 months, around 28.8% of the patients were still on osimertinib and 9% on first line TKI. That means a lot of patients have progressed, and very few patients remain on therapy after 2 years, need to further improve the outcome of EGFR mutated patients, and very few patients have very good 5-year overall survival rate, highlighting the heterogeneity of the disease. So combination of TKI and chemotherapy, is it a new strategy? No, there are various trials which have proven that TKI with chemotherapy has given a better overall survival, PFS and OS benefit, especially from a TMS study where pemetrexed carboplatin plus geftinib was compared with geftinib alone. There was an overall response rate was far better with the combination of chemo plus TKI, 75.3% versus 62.5%. And in another study, that is NEJ009, also same combination actually showed a better overall response, progression-free survival and a OS benefit. So this is regarding the various trials which used TKI plus chemotherapy. So if I have to talk about little bit more about the TMS study where geftinib plus chemotherapy, that is pemetrexed carboplatin, was used for 6 cycles, then followed by pemetrexed and geftinib was continued as maintenance. This was compared with geftinib single agent. The progression-free survival was around 16 months, almost equal to FLORA osimertinib data, compared to 6 months with geftinib with the hazard ratio of 0.51. Even with the overall survival, when we see the overall survival data, geftinib plus chemotherapy not yet matured, but not yet reached, but geftinib alone it was 17 months, again a very good and impressive hazard ratio of 0.45. NEJ009 also shows a similar result with the combination of pemetrexed carboplatin plus geftinib versus geftinib single agent, where there was a significantly substantial progression-free survival and overall survival benefit. So can chemotherapy, yes, we all know that Tagrisso basically breaches the blood-brain barrier and it acts on the brain metastasis, but whether the chemotherapy does act. So this is a paper which tells that in a patient where already there is a breach of blood-brain barrier with the metastasis, chemotherapy do act, and there are a lot of trials which actually substantiates it. Some of them are retrospective data, and the intracranial response rate with platinum agent is between 23 to 38%, and the intracranial response rate with pemetrexed is as high as 38 to 68% in various studies. So the combination of this pemetrexed plus a platinum agent with a TKI makes sense. With osimertinib makes sense. So there is one more study called GAP brain trial where geftinib plus chemotherapy, that is pemetrexed carboplatin versus geftinib. So if you see the intracranial PFS, there is a wide, the curves are wide apart and there is early separation of the graph. The progression-free survival was 15.6 months with the pemetrexed carbo plus geftinib versus geftinib with a hazard ratio of impressive 0.36. Even the overall survival, progression-free survival in the overall group also was better with geftinib plus pemetrexed carboplatin versus geftinib alone. So coming to the trial FLORA2, where this combination was used with Tagrisso, the key inclusion criteria was age more than 18 years. pathologically confirmed non-small cell squamous cell lung cancer, only exon 19 deletion and L858R were included. The PS021, no prior systemic therapy for advanced non-small cell lung cancer. Stable CNS metastasis was only enrolled, and prior brain scans was mandatory. Osimertinib, the stratification was with the 1:1 ratio. The one arm received osimertinib plus methotrexate plus carboplatin or cisplatin versus the second arm received only Tagrisso. After 4 cycles of pemetrexate and platinum, patients were put on maintenance therapy with Tagrisso plus pemetrexate. So if you see the around 600, nearly 600 patients were randomized. If you see the baseline characteristics, pretty well matched, predominantly female population, and majority of them were Chinese Asians or non-Chinese Asians. Non-Asians only included, constituted only 35% of the total study group. And if you see EGFR mutation randomization, exon 19 deletion around 61 and 60% in osimertinib plus platinum versus osimertinib arm. And if you see CNS metastasis, around 40% did have CNS metastasis at baseline. Progression-free survival, you can see the early separation of the graph, which is very encouraging, and progression-free survival with combination of Tagrisso plus pemetrexate carboplatin was 25.5 months. It exceeded 2 years. Versus 16.7 months with Tagrisso alone, with a PFS progression-free survival benefit of around 8.8 months, favoring the chemotherapy plus Tagrisso arm. So if you see subgroup analysis, almost all the subgroups did get benefited from the combination of pemetrexate platinum plus osimertinib. Say EGFR mutation status, exon 19 deletion, L858R, with patients with brain metastasis or without brain metastasis, all the subset did get benefited with this combination. And if you see the time from subsequent therapy, first subsequent therapy and the second subsequent therapy, again it favored the chemotherapy osimertinib arm versus osimertinib single agent. And most of the patients who progressed on osimertinib plus chemotherapy did receive chemotherapy, either platinum or non-platinum based chemotherapy. And in those patients who progressed on osimertinib without chemotherapy, that the second arm actually finally ended. Most of them took platinum based chemotherapy. So PFS2, again, if you see the curve, there is a benefit of around 30%, the hazard ratio favoring osimertinib plus chemotherapy. And second interim analysis, overall survival hazard ratio was 0.75 and the maturity rate was around 40%. Still very early to tell that there was an overall survival benefit, but definitely the curve is going to, moving toward, or the curve basically tells that we can probably get a overall survival benefit with the chemotherapy with the Tagrisso. Tumor response as per investigator around 83% versus 76% favoring the osimertinib and the chemotherapy arm, and the median duration of response was 24% versus 15.3%, again favoring the chemotherapy plus Tagrisso arm. So what about those patients who had CNS metastasis? The PFS was 24.9 months with the chemo plus Tagrisso versus 13.8 months with osimertinib alone. Hazard ratio very impressive, 0.47. Again you can see early separation of the curve. And higher response rate, again favoring the intracranial higher response rate, again favoring the chemo plus Tagrisso arm. So what about those patients who did not have brain metastasis upfront, and whether they were more prone to get whether they finally ended up getting more brain metastasis in Tagrisso or the chemo Tagrisso arm? So the probability of observing CNS progression at 24 months was 23% with the osimertinib monotherapy versus 9% in the chemo plus Tagrisso arm. So clearly stating that the CNS progression also decreased with the combination therapy. Yes, once we know that it has the chemotherapy plus the osimertinib has done well. So what about the safety profile and how did the patient tolerate? Most of the patients, the first line says that the total duration of osimertinib exposure was 22.3 months in osimertinib plus platinum arm and 19.3 months in osimertinib monotherapy arm. So the patient actually tolerated osimertinib better, but the problem was with the chemotherapy plus osimertinib combination, where you can see that the adverse effect leading to discontinuation was 48% with the chemotherapy plus osimertinib versus 6% with the osimertinib single agent, and majority of this was because of the pemetrexate toxicity, and in the maintenance many of the patients did not take continuation pemetrexate mainly because of the hematological toxicities. So even in spite of that, we could get an excellent PFS benefit with this combination. So what about the pneumonitis and febrile neutropenia? No much difference. Did not increase the combination of chemotherapy plus Tagrisso did not increase the incidence of febrile neutropenia or ILD. And when do we expect all these side effects? It is usually in the induction period and it gradually reduces over the time. So summary, EGFR TKI has been standard of care for advanced metastatic non-small cell lung cancer. Combination of TKI with chemotherapy offer a new first-line treatment option for patients with EGFR mutated advanced non-small cell lung cancer. The combination is seen to improve PFS in high-risk population like those with brain metastasis at presentation, and the combination do not result in any new adverse events. Additionally, need to manage the toxicity profile of the chemotherapy appropriately. So I think I have finished within 15 minutes. Thank you very much.